Assalamu alaikum warahmatullah.
Waalaikumsalam, Doctor.
Good morning for everyone. How are you today?
Morning. Alhamdulillah, fine.
Always fine. That's good. So let us start by al-Kitab. How many candidates are you?
3, Doctor.
No, I mean the total number attendance.
Okay.
It's 20. So is there anyone still not yet joined?
I think that person has connection problem, so they're trying to enter.
Must send me his name, please. Is it the first time for him to find this problem? Okay, at the end, if he didn't attend, please give me his name, okay? Let's go for the first presentation.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I will be the first presenter. So today we have 3 topics for today's problem-based seminar, which are child with altered consciousness, child with joint pain, and child with prolonged unexplained fever. Next slide. So first topic, I start off with the first topic, which is child with altered consciousness. Next. So, as introduction, the term altered level of consciousness can be used to describe spectrum of disorders, which includes clouding of consciousness, confusion, lethargy, obsession, stupor, and coma. Next. So, there are many terms to actually describe altered consciousness. First, consciousness itself means awareness of oneself and environment. Confusion is disorientation and difficulty in following commands. Lethargy means severe drowsiness, difficulty maintaining an aroused state. Obsession means decreased arousal and slow response to stimuli. Stupor is the state of responsiveness to pain but not to other stimuli, only to pain. And lastly, coma. This is the most severe form of altered consciousness in the spectrum, which is persistent state of unresponsiveness despite attempts of arousal. Next. So there are actually many causes of altered of consciousness. So to make it simple, we can use mnemonic tips AEIOU. So T stands for trauma, for example, intracranial hemorrhage. T also stands for tumor. I can stand for infection, which it can be systemic, for example, sepsis due to any infection, or neurological infections such as meningitis, encephalitis, or brain abscess. P stands for poisoning or psychiatric. S for sepsis, subarachnoid hemorrhage. A for ammonia, specifically hyperammonemia, which can occur in conditions like urea cycle defect or in liver failure. A also can stand for abuse. E stands for endocrine causes, for example, DKA, it can cause loss of consciousness. E also stands for epilepsy. I stands for insulin, and in this case, it can be either hypo or hyperglycemia. O for oxygen in case of hypoxia, and U for uremia, especially in child with underlying any kidney disease. Next. So, one of the most common cause of altered consciousness that we need to consider in children is meningitis. So, it is the inflammation of the meninges that covers the brain. The causes, it can be viral, which is the most common cause. It can also be bacterial, TB meningitis, fungal or parasitic meningitis, but this one is rare. And fungal or parasitic usually happen in immunocompromised patients only. And lastly, meningitis can also be due to non-infectious causes. For example, like malignancy or autoimmune diseases. So we may suspect meningitis if the patient has other associated clinical features such as fever, stiffness, seizure, vomiting, cold feeding, or pinprick rash in meningococcal meningitis. So the specific investigation for meningitis is lumbar puncture for CSF analysis. Next, so encephalitis also is one of the commonest cause that we need to rule out in cases with altered consciousness in children. It is the inflammation of the brain substance. And the causes include viruses, influenza viruses, chickenpox, HIV, measles, also HSV, the simplex virus. But in terms of clinical features, we may not be able to actually distinguish it from meningitis because the clinical features are more or less similar with each other. For example, fever, altered consciousness, and seizure. In infants, they can also have bulging fontanelle, similar with meningitis also, due to increase in ICP. But from lumbar puncture, we can differentiate whether the child has meningitis or encephalitis based on the CSF analysis, in which we will discuss more about this later. But encephalitis due to HSV is an important cause, but it is a rare cause of encephalitis. But we need to rule out because of its devastating long-term consequences. And this patient also mostly they do not present with false sores or any skin lesions that are suggestive of HSV infection. So in this case, EEG or CT or MRI brain can be helpful to find focal changes, particularly in the temporal lobe, which may suggest HSV encephalitis. So the specific treatment for HSV encephalitis is IV acyclovir. Next. Okay, next we go to the clinical approach of child with altered consciousness. This algorithm is taken from its protocol. So for this case, the clinical approach is a little bit different from other diseases. Instead of starting with history taking, you must stabilize the patient first because this is an emergency situation. We start with initial assessment, which is ABCD, airway, breathing, circulation, dextrose, and then assess the DCS, and then we consider tracheal intubation, and then we treat sepsis, shock, or seizure if applicable, and then we find signs of increased ICP, and then find the etiology, and then we do investigation, and lastly management. Next. Okay, for the first approach, initial assessment, we must secure the airway, breathing, circulation, and then give adequate oxygen and ventilation. And then we have to maintain the circulation accordingly. For example, we give IV bolus if the patient is dehydrated. We give inotropes such as adrenaline in case of septic shock, for example. And then chest compression if the patient is bradycardic or has poor perfusion. We also have to check the blood glucose. D in this ABCD stands for dextrose. dextrose 6, in which we have to check the blood glucose and then correct any hypoglycemia as necessary. And once the patient is stable, we must monitor the vital signs such as heart rate, BP, respiratory rate, and then monitor also SpO2 and urine output. Next. And then the second one, in the case of altered mental status, we must assess the patient's DCS. We assess it according to the EVM, which are eye, verbal and motor response of the patient. And the total score for each component is 4, 5, and 6 respectively. And please note that there are just a few differences in assessing DCS in child more than 4 years old and child less than 4 years old. But generally the component is the same. First, we must assess the eye opening. If the child can open the eye spontaneously, give the full score of 4. If the child responds to sound, for example, ask the child to open the eye and he or she can open the eye, to give the score of 3. If the child responds to pressure or in less than 4 years old can respond to pain, then the score is 2. If no response at all, give the score 1. Next, for verbal response, you can ask the child, where are you now? For example, if the child can answer the question, he or she is at the hospital, it means the child is oriented. But if the child is less than 4 years old, since we cannot possibly ask the same question, we can just observe the child. If the child can talk normally, can behave and interact normally, then we give the full score of 5. If the child looks confused, or if the child is less than 4 years old, the child only say random words that is perceived not normal for the child, give the score of 4. If the child is more than 4 years old but can only respond verbally with inappropriate words, give score of 3. If the child is less than 4 years old and can only make random vocal sounds, then give score 3. And score 2 if the patient only responds verbally with making sounds. For example, random sounds like E, for example, or any if no verbal response, give score 2. And lastly, check for the motor response. If the child can obey command, for example, ask the child to move the hands, and the child obey that command, give full score of 6. If the child can localize pain, for example, we give painful stimulus and the patient try to remove the stimulus away from his or her body, then give score 5. If the patient can withdraw from the pain stimulus with normal flexion movement, then give 4. If the patient exhibits abnormal flexion, which is decorticate posture in response to the pain, give score 3. If the response is abnormal extension, which is decerebrate posture, then give score 2. Don't worry, I will show you the abnormal posture picture in the later slide. And lastly, if no response to motor, as usual, we give score 1. After assessing all these 3 components, we total up the score. Full score will be 15 out of 15. But if the GCS is less than 8, we need to consider for intubation. And if the GCS is more than 12, we just monitor it GCS hourly. If the GCS is less than 12, we monitor it half hourly until improved. This is based on this protocol. Next. The next step is we need to consider for tracheal intubation. In its protocol, they have already outlined the indication for tracheal intubation consideration. We consider intubation if there is airway obstruction or airway is compromised by vomiting. Next is if the respiratory rate is too low for adequate ventilation. Next, if the SpO2 remains less than 92% despite giving high flow oxygen and opening and airway opening maneuver, such as the head tilt and jaw thrust. Next, if there are signs of shock even after fluid resuscitation. Next, if there are any signs of exhaustion that can reduce the child's breathing effort. And lastly, if the DCS is less than 3. Next. So the next step is if the patient is in sepsis or shock or seizure attack, we must also treat this before we move on to the next step. For example, in sepsis, we secure the IV access and then we take blood culture and then blood gas and lastly administer empirical IV antibiotics. For example, cefotaxime. If the patient is in shock, we give fluid therapy, and if the patient is in seizure, give anticonvulsant. For example, give diazepam. Next, we check for any increase of ICP signs. If the patient clinically has papilloedema, that is already established increase in ICP, but in reality, we actually have no time to do fundoscopy, right? To check for the papilloedema. So we check for any other two signs of the following, which are DCS less than 8, unreactive or unequal pupils, abnormal Dole's eye reflex, which I will explain later. Look also for decorticate or the decerebrate posturing, and lastly abnormal breathing, which are chain stops or apneic breathing, which also I will be explaining in the later slides. Next. Okay, this photo is an example of unequal pupils, which can be one of the increase in ICP signs, the picture above. And there is actually other pupillary signs in altered consciousness, like pinpoint and also dilated pupil. Next. Okay, this slide is regarding Dole's eye reflex. Dole's eye reflex is one of the eye movement reflex that we check in increased ICP sign. We know that the lateral eye movement are mediated by the brainstem structures. So it requires an intact midbrain and pons for this reflex to occur normally. So what is Dole's eye reflex? It also stands for oculocephalic reflex, in which the sudden turning of the head from one side to the other side normally causes deviation of eye to the opposite direction, as in the picture below. If the head is suddenly turned to the right, normally the eye will turn to the left, which is the opposite side. So if this sign is abnormal, it is one of the increased ICP signs. Next. Okay, this is the picture of the corticate and the cerebrate posturing, which is also happen in increased ICP. If the corticate posture, probably the problem lies within the cervical spinal tract or cerebral hemisphere. If the cerebrate posture, the problems may lie within the midbrain or pons. Next. As mentioned before, abnormal breathing is also one of the signs of increased ICP. The first one is chain stop breathing. Chain stop breathing is when there is gradually increasing in breathing depth until it peaks and then slowly decreases to a pulse. This can be seen in congestive heart failure or any trauma to the basal ganglia or thalamus. The second one is apnostic breathing. Apnostic breathing is when there is a prolonged inspiration followed by prolonged expiration, which is often mistaken as apnea. So damage in the bones can cause this type of abnormal breathing. Next, after we have stabilized the patient, it is the time for us to consider the etiology. So we have to take the history from the mother or the father and do a more thorough physical examination depending on the etiology that we suspect. We should always think of CNS infections such as meningitis, brain abscess, and not to forget cerebral malaria. If the child lives in the malaria area, and of course we need to rule out trauma, vasculitis, acute poisoning, for metabolic, DKA, hypoglycemia, and then any non-accidental injury like child abuse or shaken baby syndrome, and post-convulsive state if the patient has undiagnosed epilepsy, hypertensive crisis, ADEM or NEC, which can occur following infection as they are immune mediated. We should also consider stroke, cerebral venous, sinus thrombosis, or any acute hydrocephalus. So please read more on this etiology as it will be time consuming to explain them one by one. Next. So in order to find the etiology, we should take history. As the child's parent, we must ask the child's parent regarding the onset, whether it is sudden or gradual onset. If sudden, we may suspect ICH, stroke, or acute trauma. If gradual, we may suspect metabolic cause or infection. We should also ask the mother any other associated symptoms such as fever, rash, seizure, as this may suggest meningitis or encephalitis. We should also ask about the possible ingestion or exposure to medication or toxin, possible recent trauma, illness, or exposure to infection, or exposure to TB, as it can cause TB meningitis. And ask also whether the child has medical or family history of epilepsy, diabetes, or any other chronic illness. As for the social, we may ask about any necessary care or any potential child abuse that may lead to non-accidental injury. Next. For physical examination, we must check the skin for any evidence of trauma, and then rash, for example, pinpoint rash, as in meningococcal meningitis, or jaundice. It can have jaundice in cerebral malaria. And then check also for the child's breath for any ketone odor that may suggest DKA, and then check also for any other toxin smell in acute poisoning. And then for the head, check for the tense or bulging fontanelle, which indicate increase in ICP. And then for the nose and ears, we may check for any leakage of blood, CSF, any raccoon eye or battle sign that may suggest trauma or basal skull fracture. And then check the neck for knuckle rigidity, chronic and Brzezinski sign for meningitis. Next. Okay, the first picture is bulging fontanelle seen in raised ICP. The second picture is a raccoon eye. The third picture is battle sign, which is the bruises behind the ear, which is seen in basal skull fracture. And the first picture below is the chronic sign, in which the patient is unable to straighten the leg when the hip is flat at 90 degrees due to the hamstring stiffness and pain. This is seen in meningitis. The last picture is also for meningitis, which is Brzezinski sign, in which the patient's hip and knee will flex when the neck is flexed due to neck stiffness. Next, we do investigation. Of course, we should do all the recommended routine investigation. The first one is FBC to look for evidence of infection. Next, urea and electrolytes to look for any electrolytes imbalance. The third one is blood glucose to check for any hypoglycemia or DKA. The fourth one is LFT, liver function test in case of hepatic encephalopathy. The fifth one is serum ammonia in case of hyperammonemia. Six is blood gas to check for any acid-base imbalance, and it can also be abnormal in DKA. The seventh one is blood culture in case of infection to find the positive microorganism, and then we also need to do urinalysis, find a urine titer in case of DKA. And then there are also other option and investigation that we may do that is specific for certain diseases. For example, we do EEG. We may do it if we suspect epilepsy or, as mentioned before, HSV encephalitis. And we may do vasculitis screen if we suspect vasculitis. In case of toxin poisoning, we can do toxicology. And if we suspect inborn error metabolism, for example, urea cycle defect, we may do the IEM screening. And lastly, if the history is suggestive of malaria, we may do the blood for malaria parasite. And lumbar puncture is an important investigation in this case because we can look for evidence of meningitis or encephalitis. However, we must delay the lumbar puncture until the CT scan result has been obtained, especially if there are signs of increased ACP or any focal neurological abnormality. Because increased ICP is contraindicated for lumbar puncture because of its risk of cerebral herniation. And if the patient is considered for intubation, delay the lumbar puncture until after intubation if GCS is less than 9 because this patient may have cardiopulmonary instability. And lastly, we should do urgent CT or MRI brain for all children with increased ICP. And usually it is easier to arrange for CT brain first rather than MRI. But if possible, we consider the MRI brain within 48 hours when the diagnosis is still uncertain.
I think the word optional maybe need to be changed, recommended if indication, like every one of this, if we suspect vasculitis, okay? So it is, I don't know, sometimes optional, it means I have the right to do or not to do. No, sometimes it is very important. So indicated if the diagnosis needed. Okay? Okay, indicated according to the evaluation like that. And good that you already documented the neuroimaging here. It is very important because even CT or MRI with contrast can diagnose meningitis. We will speak about that. Okay, good. Continue.
Okay. For the neuroimaging just now,
Hmm.
for CT brain, it can offer faster result, and we can find any intracranial hemorrhage or any skull fracture. But MRI is actually better as if we suspect encephalitis and especially HSV encephalitis. Next, okay, this table is for CSF analysis after the lumbar puncture. So if the leukocyte increase and the glucose decrease, it is suggestive of bacterial cause of meningitis. In viral meningitis, the lymphocytes may be high and protein and glucose usually normal, but glucose sometimes can be low. In TB meningitis, lymphocytes and protein will be high and glucose is low. But we can also send the CSF for smear of KFB and gene expert to rule out for TB. For encephalitis, everything may be normal and sometimes it is not really specific. So we can also send the CSF for PCR virology. As we all know, viral cause is the most common cause in encephalitis. Next, for management, we need to manage the patient according to the etiology and we treat the patient according to the cause. For meningitis, we must treat with appropriate antibiotics according to the most common organism in the specific age group. The recommended antibiotic is actually already available in its protocol and plus minus dexamethasone. So dexamethasone's role in meningitis is to reduce the risk of neurological complication later by reducing the inflammation. For encephalitis, we treat according to the positive organism. But if we suspect HSV, we give IV acyclovir. And for management of increase in ICP, first we must prop up the bed at 15 to 30 degrees and keep the head of the patient at midline. And then we give adequate sedation and analgesia so that the patient is more relaxed. And then maintain good oxygenation. We must also keep the patient hydrated, but bear in mind to avoid any plain dextrose. For example, 5% dextrose because hypoosmolar solution can result in further increase in ICP. And next, we give IV mannitol 0.25 to 0.5 gram per kilogram. And mannitol is actually a hyperosmolar solution. So it can reduce the water content and reduce the brain edema, and it helps to decrease the ICP. And lastly, for increased ICP, we can consider decompression surgery. For example, external ventricular drainage or decompressive hemicraniectomy. But this one is if in case of failed medical intervention only. And it is rarely done. But just for a overview, the external ventricular drainage is a device that we insert to the ventricle to drain the excess CSF from the ventricles to the external closed system. On the other hand, the decompressive craniectomy is a brain surgery to remove a portion of the skull to allow a swelling brain to expand further outside without being compressed. But these surgeries are only the last resort and rarely being done. So it is quite advanced for our level. So if you are curious, you can always look up for it later. Next. Okay, that's all from me. Thank you.
Okay, anyone got a question?
Boleh dengar ke?
No, so thank you, Aisha. Tips AAIOH, from where you bring this mnemonic?
I found it in a journal.
Because now there is some books only making mnemonics for everything. Okay, that's good if it will help you just to remember the etiology, because sometimes you are distracted to short list for these cases, which is life-threatening, like patient loss of consciousness or whatever the situation. We must be very cautious about even the rare causes. Okay. For the resuscitating the baby, you said it is ABC dextrose, yes? Yes, I think it must be ABC 3D, not only 1D. Okay. I mean the dextrose is number one. Number two is the disclosure, okay, which will give us, is there any skin manifestation if the patient has barbaric rash due to meningococcal meningitis are very important. The second D will be disability. Is there any neurological disability? It is very important. In neurological signs, like upper motor, lower motor, which is very important in the first survey. So remember that it is A, B, C, 3D, or some are putting this disclosure like exposure, make it A, B, C, D, E, whatever you wish, but don't forget disability because it is very important also. Okay. The other thing for the one which you are speaking about, the Glasgow Coma Scale, it is very important, but you put two numbers below 12. No, yes. If it is more than 12, I need to go every hourly, okay? If less than 12, it will be half hourly. If 8 or less, I will intubate and go for continuous monitoring. It is very important. You speak after that about the indication for intubation, because it is known that if the patient consciousness is very low, up to 8, he cannot maintain his breathing. So even if you lift him, he may be shocked and die. Okay, where is this? You must add Glasgow Coma Scale is less than 8 and deteriorating. I think it's less than 8 is an important. I mean, not deteriorating, not come more than 8. Okay, and not improving for me. So it is very important to consider less than 8 is a major indication for intubation. As I told you now, don't worry before we are very afraid to start the antibiotic before giving the doing the lumbar puncture. But if there is contraindication for lumbar puncture, still CT or MRI can help us. There is something known as meningeal enhancement. Okay, even it can help us sometimes to be able to send, is it a viral or bacterial, from the shape of that meningeal enhancement. Because the vascularity of the brain are increased, and then the meninges will appear more prominent like that. So it is very important. Okay, I think the area which you spoke about, which is optional, for me it is not optional. You need to put some expression which if there is a clue or dependent on our assessment, we can recognize. Of course, some of them are not so emergent, but most of them you cannot come to conclusion unless you did it, like inborn errors of metabolism or toxicology screen. That's why many times we are collecting extra sample of the patient who came to us. We are collecting extra samples, okay, and keep it in the fridge, because it may be during that one there is no one who can give us detailed history. When someone came, we said, oh, there is a family history of early death, we have this problem, we have that problem, so we need to send a sample, okay, for inborn errors like that. So it can be available, a good blood sample for that, which we can use for toxicology, for anything. Okay, good presentation. Thank you, Aisha. Can we go for the second presentation?
Okay, Assalamualaikum, Doctor. My name is Dr Mossad and I'm charged in explaining child with joint pain. Okay, next. So this is a brief content of my outline. Next. Before we proceed, let's make sure that we know the difference in terms of this between the arthritis and arthralgia, just in case. So basically, arthralgia is pain in one or more joint, while arthritis is also a pain accompanied with another manifestation such as inflammation or redness, stiffness, or reduced range of motion. And usually arthritis will lead to a complex condition such as loss of cartilage or bone in joint, buildup of bone tissue, changes in the formation of the joint, loss of mobility, sudden severe pain from uric acid deposition in the joint, and many more. Next. Okay, when a child comes to you with a complaint of joint pain, these are the possible differential diagnoses you can think of. It is really broad. So let's approach it one by one, systematically. Next. So to make it simple, you can think about the pneumonic arthritis. A for avascular necrosis, for example, Pertis. R for reactive, such as, of course, it's from infections such as viral, streptococcal, postgastroenteritis, or sexually acquired. T for trauma, you must remember that trauma include non-accidental injury too. H is hematological, hemoglobinopathies, leukemia. R for rickets, metabolic or, for example, storage disease, and endocrine. I for idiopathic, T for tumor, benign or malignant. I for infection, such as viral, bacteria, mycobacteria, and S for systemic. Systemic disease such as systemic lupus erythematosus, vasculitis, dermatomyositis, sarcoidosis, and many more. Okay. Remember that JIA is also important, but it is not included in here since JIA is a diagnosis of exclusion. But we will go through JIA further. Next. So we proceed to history taking. This is a brief content of what you need to have in the history taking to diagnose child with joint pain. Next. Okay, before you start, don't ever forget to complete the patient biodata, as age and sex can play a role in constructing your differential diagnosis. For example, in age, it might give a clues to the diagnosis. If it is early childhood, then you might want to think about JIA, Kawasaki disease. If it is mid-childhood, then you might think of psoriatic arthritis, juvenile dermatomyositis, polyarthritis nodosa. If it is late childhood, then you might think of SLE, JIA2, and also many more. Next. So sex. Sex plays a role too. As you can see, female has a much more tendency in rheumatological disorder such as SLE, polyarticular JIA, and boys is more to vasculitis disease such as Kawasaki disease and PIME. Also includes spondyloarthropathies, inflammatory bowel disease, and enthesitis related arthritis. If it is JIA, it can occur in both sex. Okay, next. So in order to narrow down the diagnosis, you can begin with identifying the number of joints involved. So it can be divided into monoarticular or oligo or polyarticular, which is more than 2 joints involvement. So in monoarticular, which is 1 joint involvement only, you might think about septic arthritis, osteomyelitis, JIA, Lyme disease, hematrosis, malignancy. In oligo or polyarticular, which is more than 2, acute rheumatic disorders such as SLE, juvenile dermatomyositis, sarcoidosis, JIA, reactive arthritis, Lyme disease, malignancy, immunodeficiency associated arthritis, inflammatory bowel associated arthritis, and others. CINCA, cinca, is also known as the chronic infantile neurological cutaneous and articular, also known as neonatal onset multisystem inflammatory disease. Okay, you can read up later on. Next. Then determine if this joint pain is associated with fever. History of fever is really important as it can rule out many differential diagnoses. You have to know the characteristics of the fever. If there is a presence of fever with joint pain and swelling, it might indicate acute inflammation such as septic arthritis. You have to know also the time course of the fever. If the fever occur before the onset of joint pain, then you might think about reactive arthritis or post-infectious arthritis. You also have to know about the patterns of the fever. Certain disease have its pattern. For example, in JIA, it has a quotidian type-like fever, which is a daily spike of high fever, especially in the afternoon or evening, and then it returns to normal or even subnormal temperature between the fever, early morning. And then if it is gradual onset with low-grade intermittent fever, then you can think about SLE. If it is long-standing and continuous low-grade fever, then you can think about tuberculosis causes or infection causes. Next. By now, your differential diagnosis has been narrowed down. Next. Now let's proceed to the main complaint why the child come here, which is the pain. Basically, you can approach the pain using the mnemonic Socrates. So let's start with S. S indicates site. Asking the child where it hurts, asking the parents or guardian where they believe the pain is, if the child is unable to verbally answer your question. The aim is to know the location, which joint is involved, either small or large, for example, in JIA or psoriatic arthritis. Tubercular dactylitis, it involves more to the small joint. And then you must also remember that when you confront children coming to you with joint pain, children has the highest tendency compared to adult to experience referred pain. It can be that originally the pain is at the hip, for example, at the spinal, but then it can radiate to other places. So make sure you manage to differentiate between it. So O is onset. Is the pain acute or chronic? If it is sudden or acutely occur, for example, in joint or bone infection, trauma, acute deteriorations of chronic problem, If it is gradual, then you might think about inflammatory process, overuse syndrome, or osseous causes like Kaufpert's disease. Malignancy, malignancy can be also gradual, and suddenly it can be mistakenly sudden. Often has because it has often delayed presentation due to mild dull pain that may not be activity limiting in the initial stages. So if the child, if you manage to gain a history that there's nocturnal pain, then you might think about this differential diagnosis, which is malignancy. It is one of the red flags that you must consider. C is character. Helpful in older child or adolescent because basically they can pinpoint the they can describe the character of the pain. So if the pain is dull, achy, then you might think about deep tissue pathology. If it is sharp, sting, you might think about cutaneous involvement like trauma or skin lesion. If it is coming with stiffness, then you need to know when the stiffness occur. Is it early in the morning, such as rheumatoid arthritis? And then if there is swelling, does it warm to touch? That might indicate inflammation. R is radiation. For example, migratory pain in acute rheumatoid factor. You also have to make sure, like I said before, the joint pain can come, initially the pain is not from the joint, it can come to any other part of the body. So you should make sure if the joint pain is from joint or a mimicry. For example, in sciatic pain, sharp shooting pain down a lower limb. Child will say there's a pain at the limb, at the joint. And then if there is bilateral involvement, you might think about something more central causes such as cardiac renal. Okay, next. Next slide. Okay, association. You must acquire history about systemic effect or involvement, like chronic feature, like the underlying malaise, fatigue, and weight loss might suggest an underlying increase in catabolism from a systematic disease such as SLE, JIA, or anemia for underlying malignancy. If there is any extra articular features, such as JIA, they might present with salmon patch, changes in the skin. Reactive arthritis might, for example, in viral exanthema, there is a history of recurrent upper respiratory tract infections or viral gastroenteritis. In psoriasis, there must be asked for silver scaly patches, changes in the skin, changes in the nail and scalp. Hemophilia, if there is presence of bruising, easy bruising, joint swelling, and pain underlying the clothing, and pain, it may indicate underlying clothing disorder. Okay, time course. You have to note the progressions of pain over time and its response to basic analgesia. For example, you have to note if the patterns of the pain comes only on weekend. It can suggest like overuse. If it is nocturnally occur, it can suggest malignancy. You have to explore other histories such as exploring any recent viral illness or signal contact. It can be reactive arthritis, recent vaccinations such as rubella vaccinations, or antibiotic use such as cefaclor. It can cause or lead to serum sickness. Serum sickness is an immune response similar to allergic reaction by certain medication or antiserum. Usually the antigens are from the animal paste. Next. E for exacerbating or relieving factor. You have to acquire the history if there is the pain, if there's exacerbating factor or relieving factor towards the pain. For example, trauma or infection, it can aggravate by activity and it can relieve by rest. Inflammation, it can relieve by activity. Inflammation can relieve by activity as time goes by, as you move the joint, it can relieve the pain. And if it is overused, then really bed rest. As for severity, you have to know if the pain has affect the daily activities of the child, which can indicate prompt treatments, urgent treatments. For example, if the child is unable to bear weight, you must think about septic arthritis, osteomyelitis, malignancy, or transient synovitis. Limping without pain can be due to the abnormal anatomy, like leg calf Perthes disease. Pain that disturb the sleep, you might think about benign bone tumor such as osteoma, ALN, neuroblastoma. And if the severity, the degree of severity, does the pain interfere with daily activities such as walking, playing sport, and buttoning? Buttoning might indicate a small joint involvement. Next. So throughout, you're trying to narrow down your differential diagnosis. Don't forget to rule out the red flag first, because red flag is quite important. So red flag sign is such as fever, malaise, systemic upsets. Usually patient can complain with reduced appetite, weight loss, and sweating. If there is bone or joint pain with fever, if there is refractory or unremitting pain, persistent night waking, that can suggest malignancy. Incongruence between history and presentation, which suggests can be accidental injury. So there is 4 disease classified under red flag: septic arthritis or osteomyelitis, Kawasaki disease, neoplasia, and non-accidental injury. So the character of septic arthritis and osteomyelitis will be further explained later on, and Kawasaki disease will be further explained by the presenter next to me, after me. And then neoplasia, usually it presents with irritability, pallor, unexplained bruising, bone pain, which is usually nocturnal. And non-accidental injury, when you find there is disparity between given history and feature on examination, there is irritability, pallor, unexplained bruising, and other injury, and also bone pain, you might want to interview the child alone without the parents accompany them. Okay, next. Complete your history with other history. The mnemonic is FAST, family history, travel history, and social history. So family history, maybe you might want to have the history of autoimmune disease, inflammatory bowel disease, psoriatic arthritis that run in the family. Travel history is a previous travel history to endemic area that can suggest like Lyme disease or Campylobacter infection. Social history, if you found that the child is much more safeguarding, then you might want to suspicious of accidental injury, like I've explained before. One of the factor that you can suspect if there is incidental injury is problems with the child's development stage. You want to look back on the child's report. You can look at the siblings' presentation. In adolescent, you can ask for social history, such as if the parents has a history of high-risk behavior, which can have a possibility of HIV transmission, and also sexual abuse in children. Next. Okay, we go to the physical examination, divided by 4, look, feel, move, and assessment beyond joint, extra articular. So basically, look, you can start with the gait. When you can just observe the child when the child comes from a waiting room into the room for physical checkup. So simply observe the patient that come in from the waiting room lah. or observed during the play. If there is presence of limping, or you observe there is presence of abnormalities such as knock knee or bow leg that can indicate ricket. Then number 2 is review of skin. You need to find if there is changes to the skin, salmon patches and then there is rash, foreign body, hair tonic, or localized infection. Then you have to go beyond the region of interest, especially in the case of non-accidental injury. Also, don't forget about looking for other dysmorphism. And then feel, you have to inspect and also palpate. You can detect if there is a temperature change, region that are tender, and the presence of soft tissue injury, such as diffusion. Example of tender is, for example, the osteochondrosis secondary to avascular necrosis. Then move. Before you proceed to the physical examinations of moving the joint, make sure if the pain is intolerable or the child is unable to give cooperation, then you have to offer adequate analgesia. After the analgesia have finally taken effect, then you can do the assessment of passive or active movement. Then after you have done the movement, you progress to a special test of the joint. Joint specific and designed to assess ligamentous integrity, such as acromioclavicular joint in a shoulder injury. And then assessments of joint above and below the joint or the place of pain, and check for the neurovascular status of the limb of concern. Then assessment beyond the joint. In the younger and non-verbal child, especially, you have to think about GIT involvement. For example, in retrocecal appendicitis can mimic lower limb pain. Next slide. So this is the list of extra-articular signs that you can look for in a child with joint pain: eyes or cavities, skin, nail and hair, musculoskeletal, vascular system, lymphatic system, renal system, central nervous system, peripheral nervous system, paranasal sinuses, and lungs. So you might want to open back this slide and then read through it again. Next. Investigation. I divided into 4: blood, urine, imaging, and invasive or advanced. So under the blood, full blood count. Full blood count is important as you can detect if there is presence of anemia. In a normochromic, normocystic anemia, most inflammatory conditions are involved. Then you can know the extent of anemia parallels to the disease severity or activity. Total white blood cell, you can know the level of white blood cell. Leukocytosis might indicate active arthritis or systemic onset GIA, where the leukocyte count can be strikingly high. And then leukopenia, especially in SLE. Then you can also look at the platelet level. Thrombocytosis can indicate inflammatory arthropathies. Thrombocytopenia can be a possibility of SLE or leukemia. Other investigations such as renal profile, liver function test. Renal profile, for example, in Henoch colon purpura, SLE, or rheumatic fever, you might think about doing renal profile. And then liver function test, you wanted to go to see the degree of total protein, albumin, bilirubin, and liver enzyme. In my liver function abnormalities, rise in ALT especially, it might indicate JIA. Or there is abnormality in liver function tests. For example, abnormalities in liver enzymes, all of the liver enzymes, then you might think about drug toxicity, particularly methotrexate, as methotrexate is one of the drug used in interventions of a joint pain in certain disease. Okay, then you might want to do inflammatory acute phase reactants such as C-reactive protein, ESR, fibrinogen, haptoglobin, ceraplasmin, complement component. So you might want to think doing the inflammatory marker lah, such as CRP or ESR. CRP is good. It rises within 24 hours. Since it is acute significantly and fall rapidly on resolution. So you might want to use it during acute detections in disease that is acute in onset. But if it is disease with active infection, such as if the CRP is usually not elevated significantly, then it might be suggestive in indicative of active infection such as SLE. ESR, indirect measure of acute phase reactant. Increase in ESR will suggest inflammatory disease in contrast to mechanical problems such as GIA, vasculitis, and sepsis. Then you might think about blood culture and sensitivity. You might, since you have to identify, you wanted to identify causative organism for a direct antibody treatment. Okay. Serum creatinine kinase. You might want to consider doing this if it is related to heart, brain, or skeletal muscle and other tissue injury. Increased amount of creatinine kinase into the blood usually indicates there is muscle damage. Then you might think about diagnosis that have that include muscles problem. Acid titer, it is positive. If it is positive, it might indicate increase in titer of antibody formation. For example, in strep throat, there is in suspected acute rheumatic fever, there is increase in titer of antibody group A streptococcus. It might indicate evidence of strep infection lah. Coagulation profile, lupus anticoagulant, you can do this in lupus anticoagulant or hemophilia. As you know, hemophilia is something to do with coagulation factor 8 and 9. And then urine analysis and biochemistry. You might want to think about doing this if your differential diagnosis is about disease that can cause renal function to deteriorate. For example, if there is SLE or vasculitis. Imaging, you can plan for plain radiograph, ultrasound, MRI, echocardiography to see. MRI is better since you can see the surrounding tissue. Invasive and advanced, you can do consider doing the muscle biopsy, doing the EMG, or doing the ultracentesis. Ultracentesis, as you know, is a gold standard to diagnose septic arthritis, which is a red flag. Next. So we go to the management. It can be divided into three: pharmacologically, surgically, and non-pharmacologically. So pharmacologically, such as it depends on the etiology of the disease. If it is infections, if it is inflammatory type, then you might consider about NSAID, DMARDs, glucocorticoid, NSAID, DMARDs. And if it is it and it if it is not resolved, then you might think of other anti-inflammatory drugs such as non-biologic, biologic. And then if it is infection, then you might think about giving antibiotic. If it is malignancy, then you can do chemotherapy, radiotherapy, immunotherapy. Surgically, usually we do in the malignancy causes. Now, pharmacologically, for example, for in a growing pain or overuse joint pain, then you might want to reassure the patients about it, that it's normal. And then if it is about, for example, inflammatory disease such as SLE, you might to educate the patient and the parents on how to reduce the flare. Next. Okay, let's go to the certain types of diagnosis that is more common and concerning presentation, with common and concerning presentation. Next. Okay, JIA. JIA is a diagnosis of exclusion, unknown etiology, and the onset is before 16 years old. Basically, to diagnose JIA is diagnosis of exclusion after you have exclude other differential diagnosis through examination, and also investigation. So in order for you to diagnose JIA, it need to be an unknown etiology. The joint pain need to be before the 16 years old. Before 16 years old, the onset of joint pain is before 16 years old, and it is persist 6 weeks or more. So the onset is insidious or abrupt disease can be either two, with morning stiffness and arthralgia during the day. History of school absence or limited ability to participate in physical educational classes, which is basically affect daily activities. Then it has characteristic of fever, quotidian fever that I explained before. And then evanescent rash on the trunk and extremities, psoriasis or more subtle dermatological manifestation. Physical findings, you can look for evidence of arthritis and synovitis. Evidence of arthritis, intra-articular swelling, limitations of joint motion in association with pain. There are warmth or erythema of the joint. In the synovitis, you might want to see swelling, increase in joint volume that may indicate increase in joint volume. And then the pain, the patient usually wanted to position themselves in a comfort position. And usually the range of motion is also limited, especially on the extremes. Then treatment. You can refer to the PETS protocol at page 591, where there is an algorithm. It divided into three based on the number of joint involved and systemic, such as polyarthritis, oligoarthritis, polyarthritis, and systemic involvement. So in oligoarthritis, first line is NSAID. If I explain this, it's gonna take a lot of time. So I think you might want to read it by yourself at page 591. Yeah. Okay, next. Okay, septic arthritis. Oh, before I forget, JIA is the most common joint pain in children. And then proceed to septic arthritis. It is, like I say, it is a red flag diagnosis. You have to rule out it earlier because it needs prompt intervention, as within 24 hours, it can cause destructions of the joint. And usually patients who come with septic arthritis appear sicker, and it involves all age and any joint. So in the history, you might want to have a history of recent local trauma or infection, the history of vaccination and antibiotic use, symptom, is it the pain in acute onset, or is it associated with fever and other systematic symptom? If there is pseudo paralysis, which the child refused to bear weight because due to pain, extreme pain. And physical examination, you might want to inspect and palpate. Make sure you give analgesic if needed. Look for localized swelling, tenderness, and warmth. There is severe pain with passive motion. Usually, patient will tend to have specific relieving position. We will go into that later. Investigation, you might want to do for blood count, inflammatory marker, do imaging, and erythrocytosis, and it is gold standard. And then for management, early intravenous antibiotic, or if the septic arthritis doesn't improve by that, then you might think about doing surgical washout. So culture criteria. Culture criteria is important to determine the risk of septic arthritis in pediatric, as there are other disease that can mimic septic arthritis, but it is benign and limited, not such as septic arthritis, which is red flag. For example, in transient synovitis. Transient synovitis is benign and limited, but it is the same as septic arthritis in terms of rapid onset, inability to weight bear, and the difference is between septic arthritis is in terms of the appearance of the child. It appears much more healthier, and then the blood investigation is usually unremarkable, and it can just give the treatment is only based on conservative management, such as NSAID. So basically, you do this culture criteria to know if it is the presentation is much more suggestive of septic arthritis. So there is 4 criteria here: non-weight bearing on affected site, ESR, fever, and white blood count. Probability of septic arthritis, if it is 1 out of 4, then it is 3%. If 4 out of 4, it might indicate 99%, which is strong indication of septic arthritis. And from treatment and intervention need to be done that time. Okay, next.
I think this one, come back please. I think this one we must consider that there is arthritis in the issue. And it cannot come with ESR, fever, and I mean, one of these must be affected joint.
Affected joint.
Yes, because if we put ESR, fever, white count, it can be tonsillitis, any infection, any itis. But to say septic arthritis, you must have arthritis beside that, okay?
Oh.
Don't go and diagnose arthritis without any clue for that, but I will speak for it after that, okay?
Okay.
Time is running now. You have a good presentation, but you must train yourself for time consideration.
Okay. All right. Okay, next. So the positions that they might present is flexion, abduction, and external rotated, as it might increase the pressure of in the joint. Next. So osteomyelitis, it can mimic also septic arthritis. Staphylococcus aureus is the common presentations, common causal organisms, and the common presentation is involved in preschool age. Male is more to female. It's because male tend to do extreme activities. That's why they are prone to injuries and exposed to osteomyelitis. Hematogenous spread, it involved in hematogenous spread, especially to the long bone. And then the symptom is focal swelling with cardinal signs of inflammation with or without fever. And then usually the child can focal point the tenderness over the affected bone. On physical examination, there is a limited range of movement and signs of inflammation. So to investigate this, you might think about do the blood demonstration, full blood count, leukocytosis, then inflammatory marker, obtain the culture. You can obtain the culture in blood, bone, joint, or do a joint aspiration. Imaging, you might want to see if there is periosteal change that might that later on can progress to lytic bone, and you might want to do MRI to see the tissue tissue surrounding. Management is intravenous antibiotic. If it doesn't there is no remission with antibiotic, then you might think about doing bone biopsy. If there is intraosseous abscess formation, then you might think about doing the surgery. Okay, next. Okay, that's all. Thank you. Any questions?
So why
No?
you know? Just remove it. Okay. It doesn't need any questions, so you can increase the number of questions to here. Yes. Speak. Hello. Who was speaking before? There is one asking a question.
Yes.
Any question? Now I think Sarah did a nice job. I may ask Aisha just to do also about 3 cases of loss of consciousness. One of them may be endocrine, like DKA, one infection like meningitis, and the third one for you. Okay, Aisha? The other thing, one applied important point is the issue of examining one joint below and above. I mean, for any arthritis, I must go ahead for all the body. I will draw all the joint and comment what is the joint affected and draw it for follow-up. But even for small children, this one to go up and one joint up and below, if you suspect it is like a single mono arthritis, genetic arthritis or other. For infants, usually you cannot detect the hip joint arthritis. Sometimes that picture which you present by your colleague appear, but sometimes you cannot be kept. Only limitation of movement, and you are not sure is it in the knee or in the hip. So don't forget the hip joint disease. Of course, extra articular manifestation, a very, very important point we must remember, and don't stand on the diagnosis of arthritis until you are going for all extra articular manifestations. Okay. Bone biopsy now, I think they are doing something like as biofilm. Biofilm, sometimes you cannot culture result positive. So the most diagnostic one is during operation or during opening for the joint, you are getting a swab from the periosteal itself. It's known as biofilm, and this one of the most diagnostic and give you clue. But remember that osteomyelitis, it needs how long antibiotic course?
Osteomyelitis antibiotic extended to, forgot. Sorry, doctor, I forgot.
It is very important to know.
Yeah.
intravenous antibiotic at least 6 weeks.
6 weeks. Okay.
We need the antibiotic at least 6 weeks. It may be the first 3 months, 3 weeks can be given intravenous, and it may be we're able to change it to oral, but we need antibiotic at least 6 weeks. Okay.
Okay. Thank you,
But
Doctor.
not needed to be all intravenous. Some are taking a decision if small baby to intravenous, some may oral up to 3 or 4 months, or 3 or 4 weeks. Okay, good. Let's go for the last presentation, and we can ask inshallah at the end of that one.
Hello. Okay, my name is Anis Arisha, and for our last seminar topic today, I will present about the child with prolonged unexplained fever. Okay, next. So I will start with the concept first, and I will end with the overview of important disease in prolonged fever. Next. Okay, so we start with the concept of the fever first. Next. Okay, the fever can be defined as the rectal temperature 38 and above, and if more than 44 Celsius, it is called hyperpyrexia. And physiologically, our body has a range of the body temperature that range between 36.6 to 37.9 Celsius, and our body also has a temperature of the diurnal variation, which temperature is highest in early evening and lowest in the morning. Next. Okay. Okay. So physiology of fever, it started with the stimuli that can be due to bacteria, viral, protozoa, or immune reaction, or drug malignancy or inflammatory disease. Because this stimuli we trigger phagocytic cells such as macrophage to produce cytokine pyrogens such as interleukin-1, 6, and TNF. Hence, cytokines we initiate the synthesis of prostaglandin in anterior hypothalamus. So anterior hypothalamus, we increase the thermostat set point, and then then it will induce the heat production by shivering and conserve the heat by vasoconstriction of the blood vessel, causing the blood flow away from periphery, and the patient will have chills. Okay, so when there is an increased production of the heat in our body, so there will be increased the core temperature, and it will reach to the new set point that will causing fever. Yes. Okay. Next we start with fever of unknown origin, or known as FUO. FUO is temperature more than 38 Celsius, which the causes could not be identified after at least 8 days of evaluation by healthcare provider. Yes. Okay, so for the subtypes, okay, under FUO, we have 4 types of FUO, which are classic FUO, healthcare associated rickets-related FUO, immunodeficient FUO, and HIV-related FUO. Each of these subtypes have different group that commonly affected and also have different the causes. Okay, for example, in classic FUO, it is commonly affect on previously healthy patient, and the common causes can be due to cancer, infection, inflammatory, undiagnosed disease. Okay, next. Okay, in FUO, I divided the etiology into infectious and non-infectious. Okay, so for infectious is the most common cause of FUO. Okay, under infectious, it can be to localized infection such as abscess, infective endocarditis, osteomyelitis, pneumonia, and bacteria. It can be due to cat scratch disease, leptospirosis. Viral can be due to cytomegalovirus, hepatitis virus, HIV, and fungal, it can be due to histoplasmosis that commonly occur on immunodeficient patient. And for parasite, it can be due to amoebiasis, malaria, and toxoplasmosis. Okay, so the most common causes of FUO it is cat, cat scratch disease, tuberculosis, and leptospirosis. Next. So under non-infectious, it can be due to inflammatory, such as juvenile idiopathic arthritis, SLE, neoplasm, commonly due to leukemia, lymphoma, and miscellaneous that can be due to factitious virus. Okay, factitious virus is the fever that created by the patient, which the patient manipulate the thermometer by putting thermometer in the hot water because the patient want to obtain medical care or want to get absence from doing work. Okay. However, for the factitious virus is commonly occur on children less than more than 10 years of age. Because they are unable to manipulate the thermometer. Yes. Next. Okay. So we start with the approach, how to approve the child with fever of unknown origin. Okay, next. Okay. First we go to the history first. Next. Okay, for the history, first we need to know the characteristic of the fever. Okay, before we go specific to the fever, we need to know the age of the patient because different age have different common etiology. Okay, for example, if children is more than 6 years old, it can be due to respiratory or genital tract infection, localized infection, GIA, or leukemia. Okay. Next, after we have know the age of the patient, we go to the characteristic of fever. Okay. First, fever, we ask about the onset, when the fever started to occur. And then we need us to ask about the frequency of the fever occur because some fever, because some disease can have continuous fever. Okay, and then the duration, because we want to because we want to ascertain that that this fever, that it is fever of unknown origin. Okay, next for the pattern of the fever. Okay, a specific disease has specific pattern of the fever, such as continuous fever, relapsing fever, that I will be explaining later. Okay, Next, we also need to ask, is that the fever is respond to treatment, for example, antipyretic, because if the fever is respond to antipyretic, indicate that it might be due to infection or inflammation. And then ask about is that children, is that the children has repetitive chest and temperature always spike to indicate septicemia. Okay, next. Okay, so for the pattern of fever, okay, there are 5 common pattern of fever. Okay, first I will start with the continuous fever, which fever does not fluctuate more than 1 Celsius during 24 hours. But at no time but at no time it does not touch normal. Okay, so in simple meaning, so in simple meaning, continuous fever, the fever always occur and it does not reach to the normal temperature. It can be due to pneumonia, typhoid fever, and UTI. Okay, next. Next. Okay. Okay. For example, under continuous step ladder fever, we have a typhoid fever. As we can see.
Mute, please. Everyone mute his microphone, please. Only Anis, okay?
Sorry, Dr. Wan. I'm sorry for the sound. Okay. Okay. We go to continuous step ladder fever that commonly pattern of fever in typhoid fever, because I can see that the fever is step up slowly. Next. Okay, next for intermittent fever, it occur because of the exaggerated circadian rhythm that includes a period of normal temperature or most day. Okay, as you can see on the picture, there is black line, right? Black line to indicate intermittent fever, which fever occurs and then it will go down to the normal temperature and then fever occur again. So it has high spike and rapid effervescence. It can be causes due to pathogenic infection, lymphoma, and TB. Next. Okay. Next for the intermittent fever, the fever is persistent occur and it's vary by more than 0.5 Celsius per day. Okay, so as you can see on the picture, on the orange line, okay, for the intermittent fever, the fever always fluctuate. However, it does not reach to the normal temperature. It can be due to viral infection and infective endocarditis. Next. Okay. Next for relapsing fever, the febrile periods that separated by interval of normal temperature. Okay, for example, it can be due to malaria. Okay, so as you can see on the picture, for the malaria, it can cause tertiary fever, which fever occur on the first and third day. So between of them is febrile. Okay, next. Okay. Last Pilipstium fever. The Pilipstium fever is a characteristic of Hodgkin lymphoma, which fever lasts for 3 to 10 days, followed by a febrile period for 3 to 10 days. Okay. Next. Okay. Next for okay, so after we have has the history of the fever, next we need to ask about associated symptoms. Okay, such as we need to ask any chills or rigors to indicate bacteremia and malaria. For rashes, for example, juvenile hepatic arthritis that can has salmon rash. Okay, for the night sweat, it commonly occur on TB and lymphoma. For cautionary symptom, commonly due to TB and malignancy. And then for red eyes, such as Kawasaki disease, nasal discharge due to rhinosinusitis, the sweat, and then is there any swelling, especially at the neck, to indicate TB and also malignancy. And then we suspect the patient have thyrotoxicosis, we need to ask any sweating and heat intolerance. Next. Okay. Okay, and also for SLE, ask for any skin rash, malar rash, photosensitivity, and also ask about respiratory symptom, which commonly occur due to pneumonia. And then for gastrointestinal symptoms, such as nausea, vomit, diarrhea, that can be due to salmonellosis, leptospirosis, and inflammatory bowel disease. Next, for lower urinary tract infection, that can be due to urinary tract infection. However, not all of the children will have lower urinary tract symptom. And then ask for any neurological symptom to rule out brain abscess, toxoplasmosis. And then for the limb or bone pain, as has been explained by previous presenter, that can be due to osteomyelitis, septitis. Okay, next. Okay. 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 After associated symptom, we go to the other related history, because in other related history, we want to know the source of fever. Okay. Okay, first we ask about the exposure. Is that the children has any recreational water sport? Because risk of the leptospirosis, and also ingestion of outside of the food, risk of the salmonellosis, and also sick contact with recent dental procedure, especially in patient that has congenital heart defect rheumatoid heart disease, because they has high risk to develop infective endocarditis if they do not take antibiotic prophylaxis for dental procedure. And then for the animal, we ask, is there any scratch or bite by the pets, such as cats, because for the cats it can has high risk to get cat scratch disease. And then for drug history, immunosuppressive therapy, because if the children is take immunosuppressive therapy, they are in immunodeficient state, so they are more risk to develop severe infection. And then as any recent drug taken, because drug fever also can occur, although it is uncommon. Okay, then for past medical or past surgical history, we ask any history of the previous severe or chronic infection to indicate that the child might has underlying immunodeficiency. And then abdominal surgery for intraabdominal abscess, and then any tracheostomy tube or implantable device, because they are high risk of infection. And then for history, malignancy. Next. Okay. So next for diet history, for the Okay. So for diet history, we ask about any consumption of raw or undercooked egg because risk of the salmonella, and then if the children has pica, that can be due to iron deficiency anemia. The children may eat that can be risk of toxoplasmosis. Next, we also need to ask about immunization history, whether it is updated or not. Because the meningitis can occur if the patient does not take BCG vaccination. Okay, next, for history of the traveling to endemic areas such as malaria, if the patient is go to the jungle. Okay, and then for prophylactic immunization, we need to ask before the child go to travel, does he or she take any immunization? Okay, and then social history, we need to address any outbreak in housing area. And lastly, we also need to know does the fever has impact on the child's health activity because the child has prolonged fever, so the child will become inactive. Okay, and also we upset. Also we affect go to the school because the child need to take absence. Next. Okay, next. Okay, so next for the physical examination. Yes. Okay, so for physical examination, we need to examine from the head to the toe because the causes of the prolonged fever, because they are lost. Because there are numerous causes of prolonged fever. Okay, first we start with general appearance, which we look the patient. Is that the patient is sick to indicate TB malignancy, and then toxic looking due to sepsis, and then in respiratory distress due to respiratory infection. And then for the nail, look splinter hemorrhage for IE, and then clubbing that can be due to congenital heart defect, because congenital heart defect can be risk to develop IE. And then for the eye conjunctivitis such as Kawasaki, rose spot in IE, proptosis in orbital infection. Next for the next we go to the mouth, which we look is there any oral ulcer for SLE, oral thrush, to indicate that this patient might have oral candidiasis that may prone to develop pollen fever. Okay, and then strawberry tongue for Kawasaki, gingival hypertrophy for leukemia, and then for the red mucous membrane for Kawasaki. Okay, next. Okay, next, for sinus, we palpate the sinus, such as at medullary sinus, ethmoid sinus, to look any tenderness, especially if child has persistent nasal discharge. Okay, next for the skin, we look for malar rash at the face, and then erythema nodosum. Nodosum that can be due to malignancy, and then salmon pain rash can be due to GIA, and then skin peeling due to Kawasaki and MPTC that can be due to septicemia. Then for lymph node lymphadenopathy, especially if we suspect patient has TB and malignancy, such lymphoma, And then for the thyroid, we palpate to look for any enlargement and tenderness for thyroiditis. Okay, and also not to forget, also take the vital sign, because in some patient they will have bradycardia. Some disease has bradycardia, such as typhoid fever, and then take need for pneumonia. Next. Okay. After we have infection general, we go to the systemic infection examination. Okay, so as usual, we start with the cardiovascular, because we want to see any murmur if we suspect IE, and then for respiratory, to look and is there any crepitation or ductal percussion for pneumonia, and pericarditis for pericarditis in SLE. And then for abdomen, it commonly due to abscess at abdomen. For example, hepatosplenomegaly, abscess liver and spleen due to IE, erythema tenderness, loin tenderness due to psoas abscess, and then musculature tenderness or effusion joint, such as in GIA, and then hyperactive tendon reflex in thyrotoxicosis. Next, for the rectal, you want to see is there any perianal fistula or fissure for abscess at the perianal. Next. Okay, last we go to investigation. Okay, next. Okay, so for investigation, these are the common investigation that we need to do with in prolonged fever. Okay, first we start with the full blood count, which we see at the hemoglobin. Okay, for hemoglobin, the patient can has high risk of for anemia, such as in malaria, and also chronic inflammation, and then neutrophilia for bacteria, lymphocytosis for viral, eosinophilia for parasite or fungal infection. And then for thrombocytosis, is commonly high in Kawasaki disease, and also it is non-specific marker for inflammation. Okay, blood smear with GIMSA if you suspect malaria. Okay, however, on this slide, there is a correction, because for malaria, when we do thin smear, we want to know the species of plasmodium that causes malaria. And then for thick smear, we want to know is there any plasmodium. Okay, I will correct later. Next, inflammatory markers such as CRP and ESR. Okay, for inflammatory marker, we need to do because we can monitor the disease progression after we start the treatment. Next. Okay, next, for urinalysis and urine. Okay, for urine, we must do because UTI is the most common causes of prolonged fever. Okay. Okay. So if suspect UTI, there might be pyuria and bacteria and also nitrate. Okay. Okay, next we go to for blood culture and sensitivity. If we suspect bacteremia, and also blood culture sensitivity was also for the treatment in antibiotic. Next, for serological test for HIV rapid test, because high risk of immunodeficiency, and also ELISA, for example, for EBV. And then connective tissue disease screening, such as ANA and anti-dsDNA for SLE. Yes. Okay. Okay, so for TB workup, for TB workup, such as sputum AFB, mental test, and sputum MTB cardiac activity. Okay, next for the chest X-ray. For chest X-ray, we want to see any infiltration such as consolidation, periheliosis that may indicate pneumonia, and then lymphadenopathy at high hilum, size to that can be due to TB and lymphoma. Okay, next for echocardiography must be done in infective endocarditis. Okay, because we want to confirm that because it is diagnosis for IE. Because in IE there will be vegetation and buff leaflet. And then for abdominal ultrasound for intra-abdominal abscess. Next. Okay, so this is the summary of how to approach the child with prolonged fever, which we start with the history and physical examination. Okay, next. Okay, so for general management, basically the management depend on causes. Okay, for example, if we suspect the child has bacterial infection, so we give antibacterial, antibacteria. Okay, and then supportive therapy such as nutrition, because if the child is malnourished, there is high risk to develop severe infection, and also for hydration. Next, we also need to monitor vital sign. Then give antipyretic for fever, and also referral to the specialist if the causes of the fever still not know after we have done initial investigation. Next. Okay, so prognosis basically it is good prognosis because prolonged fever usually occur on a typical present because the prolonged fever usually due to a typical presentation of common childhood illness. And in many cases, most does not have diagnosis, and fever will resolve spontaneously. However, 20% of children still have fever, even though the cause of the fever still do not know. Next. Okay. Lastly, we go to overview of important disease. Next. Okay, in prolonged fever, we need to rule out Kawasaki disease, especially on children less than 5 years old, because in Kawasaki disease, there is complication on the cardiac, such as aneurysm of coronary artery. So Kawasaki disease is systemic febrile condition due to systemic vasculitis. Diagnostic criteria for Kawasaki disease. It has fever at least 5 days, and also five out of the following or in mnemonic cream. For the cream, we start with C. C is conjunctivitis. And then for art rash, they usually truncal. And then A for A, adenopathy at the cervical. Okay. And then E for edema in extremity, or erythema. And also the extremity also can has periungual discoagulation. And then for M, mucosal changes of oropharynx, such as injected pharynx, red lips, dry fissured lips, and strawberry tongue. Okay, so for Kawasaki disease, it's usually clinical diagnosis. Next. Okay, however, there are also some children does not have all criteria that I have explained before that we call incomplete Kawasaki disease. However, incomplete Kawasaki disease should be considered in infant or child with prolonged unexplained fever, and then the criteria less than fewer than 4 of the principal clinical feature, and also the child has laboratory or echocardiography finding similar with Kawasaki disease. Because for this child, he is at higher risk to develop coronary artery dilation or aneurysm. Echography will be indicated in patients that have prolonged fever with two other criteria, which CREAM, and then the patient has subsequent unexplained periungular discoagulation at the extremity, and then or the patient has two criteria, and thrombocytosis or rash without any other explanation. Next. Okay, so investigation for Kawasaki disease is commonly true if we suspect in incomplete Kawasaki disease, and also we want to see complication. Okay, in Kawasaki, from full blood count, there will be anemia, leukocytosis, thrombocytosis. Inflammatory marker will be elevated, and then for liver function test will be low albumin and raised AST. For UFAM, there will be pyuria, and then for echocardiogram, the most important investigation is echocardiogram, which we want to see is there any aneurysm in the coronary artery during acute phase, which if within 6 weeks. Next. Okay, so for the treatment in Kawasaki disease, first we give IV intravenous in immunoglobulin. Okay, next oral aspirin, because we want to prevent thrombosis, and for maintenance we give oral aspirin or until ESR and platelet count normalize. If coronary aneurysm present, then continue aspirin until resolve. Okay, that's all. And next. Okay, that's all. Sorry for any disturbed sound.
Okay, that's good. Any question? Hello? Can you hear me?
Yes, doctor.
Yes, doctor.
Yes, doctor.
Is there any question?
I would like to ask question.
Okay. Let us give a good point from yes.
My question is, sorry, doctor. Can you hear me?
Yes, yes.
Okay. I would like to ask question to Anis. What are the patient presentation for complication of cardiac in Kawasaki disease? And I would like to ask doctor, we screen the aneurysm complication. Can you hear me, doctor? Okay. I will ask the third question to Anis first.
Yes. What is the third question?
Okay, the complication of Kawasaki disease on cardiac. Okay, so common complication for Kawasaki is coronary aneurysm and also thrombosis. That's why we need to do echocardiography during the first presentation of the patient.
So what are the present? Okay, is it acute? Yeah, it's acute presentation. So common presentation of aneurysm.
Because some patient does not have any symptom. So that's why we need to do echocardiography.
Okay, thank you.
Yes, of course. Sorry, I need to switch off the camera because the internet in the hospital is not so good. The issue, Kawasaki can affect the heart by many types. Okay, even myocarditis, even endocarditis, like that. But the most common and the most prominent one for it is coronary artery aneurysm. Okay, which if not diagnosed early and given treatment, it can cause a very bad side effect. If we diagnose early and start the treatment, it is a good prognosis. It may need to give prolonged course of like aspirin and follow up, and most of the cases are responsive nicely after IVIG and aspirin. Okay, and this is a good point about your question. Usually, a lot of doctors are thinking how to be just a doctor and they can collect some money and like that. And this is not a good ambition, please, even from the Islamic point of view. Now, the world is the world of subspecialty, the world of subspecialties. So we must be keen. Please planning to choose subspecialty. So after going soon to your house officer, you can go for MO, you can go for master, you can go after that for subspecialty. So you can be a referee for some sophisticated point, because if you are general pediatric, you are covering all subspecialty. But if you are covering a single important subspecialty, it is the time which you can give more benefit to the country. I know all of us mustn't be like that, but I think everyone must go through this question and try to plan early to go subspecialty so he can come to the very, very deep details. We can get, a good important point from the presentation is something which is the fever pattern. It is very important, which means I must be a good listener to the family. How is the fever, how it is. And now inside our IB circuit in the hospital, you can open the temperature chart and you will find it. And sometimes temperature chart, as your colleague Anis spoke, it is very, very rich in knowledge and the diagnostic ability. The second important thing for all of our presentation today also, at some times of our medical practice, many doctors think their own responsibility of to give antibiotic for infection. And we are trying to change this concept. Not all the diseases which presented to us are infection. And even if infection, most of the infection are not bacterial. It may be many cases are bacterial, but viruses many times are exceeding the bacteria. Fungal and the other is rare, but also must be considered, okay? So please always think about the immunological disease, okay? Systemic disease is very, very important. Other than go for infection and you forgot that. And even if you got infection, you must be able to diagnose the one which we didn't present with arthritis is the rheumatic fever. It is start as infection of tonsillitis, but it will after that come as a polyarthritis, which is fleeting polyarthritis. Okay, the issue for investigation, just to remembering all of you, I prefer just to remembering you that it will be lab investigation, which include whatever you are doing, a septic profile, you are doing a full blood count, you are doing immunological test like that, okay? And radiological investigation, and you must put a third one, which is the bedside test, like your colleague speaking about patient of convulsion or loss of consciousness. I need to do RBS, the patient with like that. So there is bedside test, the patient with asthma or respiratory distress. I need to do arterial blood gas and pulse oximeter like this. So it may be lab and rad and bedside tests, and every disease has its own important bedside test. Even sometimes you need to go through patient with severe hypertension. You need to ask to see the bottle of the urine. It may be glomerulonephritis, okay? At the last one of the pillar of the investigation, other than lab, rad, bedside, is the specific presentation. Even if this specific is one of the before. Any disease you are seeing, you must ask yourself. So if I asked you now, what is the, for Aslan, what is the diagnostic test for SLE?
Sorry, doctor. Can you repeat?
Specific diagnostic test for SLE.
Okay. To diagnose SLE.
Yes.
Is it your question? Oh, okay. So for the diagnostic, your question right, diagnostic right. So I will screen for autoantibodies and ANA, anti-nucleic acid, and also double-stranded DNA.
Which one?
ANA and double-stranded DNA. Doctor. So
So the diagnostic guidelines, we need to start by the DNA, but the standard is the double strand. So now, Zahra, what is the specific test for glomerulonephritis? Glomerulonephritis.
I'm not sure, doctor.
So who can answer?
Can I try?
Yes.
Is it urine microscopy to look for microscopic hematuria?
What is most important than microscopic hematuria is the RBC.
red cell counts.
Yes, it's very important. This is one. What another important diagnostic test? It is diagnostic for it.
Anti-streptolysin.
Good. ASOT, if you suspect
SOT.
it is post-streptococcal. If we suspect it is post-streptococcal, it will be ASOT or better DNAs, which is more specific. Okay. But still, there is one important test also will help us, which is the
renal biopsy.
C3 and the C4. Okay, very important. C3 and the C4. You cannot diagnose it, especially if it is mixed picture between nephritic and the nephrotic, until you do the C3 and C4. So now we have some diagnostic test like that. What is the diagnostic test, Farah? is for acute septic arthritis or septic arthritis.
Electrosynthesis, doctor.
Sorry?
Electrosynthesis.
Yes. So it is very important. I will go directly and get a sample from the joint aspiration itself, which will tell me the truth, because sometimes it doesn't come to be bacteremia or septicemia like that. So it is very, very, very important. What is the bedside test, Hamiza, for meningitis or meningoencephalitis?
Bedside? Is it lumbar puncture?
Yes, not is it, it must be it. Because if I am not able to do it, whatever the cause, like there is infection in that area, the patient consciousness is not okay, the increase intracerebral pressure, whatever, I must go for treatment blindly for 2 weeks or more, okay? For TB, I will ask whom? Another Farah. I saw 2 Farah, yes? Farah Amanina.
Is it Mantu test?
One of them is Manto test, okay, or purified protein derivative. What other?
Can we do IGRA, doctor?
Do what?
IGRA.
Yes. IGRA, yes. This is a very important test also. It is compared now with the Manto test, because Manto test or protein BBD sometimes has positive and negative results, okay? False positive and false negative. IGRA, of course, the blood culture, the culture is a diagnostic, but it will take up to 3 months. Okay, that is the most important. For leukemia, Hamiza? What is the diagnostic test?
Karyotyping? Leukemia.
Karyotyping will help you for some types of
Bone marrow aspiration.
Yes, this is the gold standard. Blood film and the bone marrow aspiration. So even if you have a lot to speak about, I am going to do for blood count, renal function test, liver function test, septic profile, I would like to do blah, 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 blah. You must ask yourself at the end, what is the special or pathognomonic test for my case? Okay, maybe dengue fever. I will ask for specific for dengue fever. It will be either NS1 or IgG, IgM, like that, accompanied by full blood count, which will give me a lot of idea about the issue. So it is very important to ask yourself about that. Okay, so please don't forget, and don't forget that all this presentation sometimes it can come together. So we need to mix Aisha and Maisara and Anis in some cases, as your presentation before, a patient with infective endocarditis, okay, or even with rheumatic fever and good complication like thrombosis, like that. So you can get all the presentation, patient with fever, with arthritis, with even disturbed consciousness, all can accompany together. That's why my responsibility is to put just a software in your brain, how to think, how to go deep through the history, which will offer you a good amount of knowledge. But in case of emergency, you must go as we speak, A, B, C, D, E, like that, or A, B, C, 3D, whatever, and concentrate in stabilizing the patient. But at the same time, we'll ask another colleague, please go and squeeze the history, because it may be one word make everything clear for me. He is a known patient of of diabetes mellitus, and he got his insulin today, but he ran before getting his breakfast. So I will know that this patient is coming for hypoglycemic coma. He is not keen, he is not compliant for the treatment. Now it is hyperglycemic coma. So even the history will guide us a lot, and then our clinical examination, and then our investigation. I hope today that you got an idea about the critical care. The critical care is the top importance, okay? Most of people are afraid from that, but really it is one of the, I think, which you can find Allah in your way. Because sometimes one is going to die, and you are able just to resuscitate him, and he escaped, and you can diagnose him, and the treatment to give benefit for him. That is the point which between true life and the true death, not the quality of life only, like most of the subspecialties. So it is a good also to consider the emergency medicine, okay, is a very important if you are keen. And really, it is a very good, yes, it may be stressful like ICU and emergency medicine, but for my opinion, it is a very good job, which if you did it professionally, you will find the result of your job. We are not interfered with the ajal. For everyone has his ajal. He may come to us, nothing done, he already came, collapsed at home and expired like that. But sometimes we are able to do diagnosis on time and the intervention on time. Hoping, inshallah, I will see you either intensivist or subspecialist, and try always to process every knowledge coming to you. History is your key. Your clinical skills and the examination is your personality in medicine, which you are evaluated for that. At the end, your investigation mustn't be blanket one. I must know for every test what I need, what it will give me. So yes, I will do lab, I will do RAD, I will do some bedside test, and I will ask myself if there any specific test mustn't be missed at this situation. Okay, I hope you got the message today, and I hope, inshallah, to see you again. At the end, anyone has yes. So nothing. So we can pray Dhuhr 30 minutes late. Okay. See you, inshallah, again. If someone is absent, please, you must inform Farah, discuss, okay? Because I saw the number came to 27 and then come back to 26. Okay. Assalamu alaikum wa rahmatullah.
Thank you,
Doctor.
Doctor.
Waalaikumsalam. Thank you, Doctor.
Welcome. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.